Welcome back, everybody. Our next speaker, Mr. Benjamin Clarke, is a vitreoretinal consultant surgeon who practices in Gloucestershire at Cheltenham General Hospital, amongst others. He recently operated on our first speaker, Tal Goldsworthy, propelling Tal into a technicolor world of micro detail and vastly improved vision. Ben will talk about surgical procedures for Ectopia Lentis and other problems. Welcome, Ben.
Many thanks for having me to talk. It's a real honour, and really been enjoying the talks so far. So yeah, as Victoria said, I'm based in Gloucestershire. I'm a surgeon who operates on eyes. So my bread and butter work is retinal detachments, and I also do some cataract surgery. So for situations where the lens is unusual, that lends itself quite well to alternative solutions. So hopefully I can take you through a little bit of that today. To talk about the different options, we do have to go into quite a lot of detail, and I'm aware that some of you may have either encountered this situation yourselves or had family members who've gone through it, so you may be very up to speed with all the details and the anatomy and whatnot, and some of you may not be. So we'll just revisit the anatomy of the eye so that everybody is aware of what we're talking about. We'll talk a little bit about the effect of Marfan on the lens specifically, different options for surgery, and then I'll take you through my technique, which Tal Goldsworthy has experienced himself. So looking to the anatomy of the eye, so this is cross-section through a human eyeball. So the top of the slide shows the front of the eye, and the bottom of the slide shows the back. If we look at the structures going front to back, all important for vision, obviously. So the cornea is the glassy surface on the front of the eye. Moving backwards, you've got the iris, which is the coloured part of the eye, and the hole in the middle of that is the pupil. Behind the pupil sits the natural lens, and that is supported by these zonules or zonular fibres, which we've coloured in red there. The eye is filled with vitreous gel, which is just a clear substance. So moving through that, you see the macula at the back of the eye, which is your central vision area. And then the optic nerve is the cabling which sends all these messages to the brain. As surgeons, we like to keep things simple, so we say either anterior chamber or posterior chamber. So the anterior chamber is anything in front of the pupil, whereas the posterior chamber is anything behind the pupil. So when we're seeing things, the light rays come in through the surface of the eye, they pass through the pupil. A lot of the focusing is actually done by the cornea, so the light rays come a little bit together through the cornea, and then the lens is responsible for doing the fine tuning. So that focuses near or far, and it brings all the light rays together so that you get a clear image at the macula at the back. So that's a situation where you can have really crystal clear vision, 20/20 vision. This is a patient on my surgical table. You can see a sort of a clear plastic drape covering the eyelids, so it doesn't look quite normal, but there's a little metal clip also holding the eyelids apart. Also, the pupil has been dilated with drops already, so we've got a big pupil. But if you look within the center of that pupil, you can see a sort of an orange glow, and there's a little crescent there, which is the edge of the lens. So the lens has shifted, it's off center. So this lens has moved towards the right of the screen. So if I was able to show you the rest of the lens, it would look something like this. So it's sort of oval in shape, and it's sort of moved and tilted. So that is compatible with vision, but not perfect vision, because this person will be looking through the edge of that lens, which is a 3D shape, and it's curved. So actually the focus is not going to be good in this situation. So in Marfan, the zonules are the primary site that's affected. So these little fibers which are holding up the lens, they become weakened, so they can either stretch or they can break, either of which can cause the lens to move. So when the lens moves, we say subluxation. If all the zonules snap, then we say it's a dislocation, so the lens can fully move to the back of the eye. So a little bit like that. So that's a subluxation where the lens has tilted. So this person will still have vision, they'll still be able to see things. But if we go back to those light rays coming into the eye, they're going to be diverted off in a different pattern to how they would have been when the lens was straight. So the image that forms on the back of the eye will be confused, it will be defocused. The vision will be there, but it won't be the same quality that they will have had before the lens moved. So for a lot of people, this is a situation they can't tolerate, rightly so. So if I'm doing a normal cataract operation, so this is taking you back to an eye without Marfan, we need to have access to the lens so that we can change it. So we make a little cut in the cornea on the surface of the eye. So we've just done a little tunnel to the left there. The next step is to make a hole in the front of the capsule. So the capsule is a sort of the bag which surrounds the lens. It's a bit like cling film, but it's a natural structure. So we make a circular opening in the capsule, and that allows us to take the lens out of this capsule, but leave the capsule intact. So then we take a plastic lens which can be rolled and inserted into the eye, and then it unfurls within that capsule. So this is a really nice position to be in because the capsule then fibroses, so it clamps down a little bit and holds on to that plastic lens really tightly. So potentially that lens is in place and doing a good job for the rest of that person's life. So that is a fantastic situation. It's a surgery which has evolved and evolved over time, and a slick surgeon can do that in about 6 or 7 minutes. It's done as an outpatient and usually just drops to numb the eye beforehand. So normal cataract surgery is a really nice operation and can bring a lot of benefit. This is a lens that we implanted just this week for a normal cataract surgery. So you can see it's sort of got 2 components to it really. It's got a disc in the center, which is the focusing part, we call it the optic. And then it's got some arms coming out either side, which serve to hold the lens within this capsule, and they're called the haptics. So this is flexible plastic. It can be rolled up, and then it unfurls inside the eye into that sort of shape. So that's a really nice design. Going back to our eye with Marfan, we've got the stretched zonules holding the capsule. So neither of those are any good to us anymore. So in fact, most cases, we just end up removing the zonules and the capsule and the lens all in one go. So we take those away and we're left with an eye without much support for a natural lens at all. So the different options that we've got available, we can either look to the anterior chamber or the posterior chamber. So there's a few options out there. The anterior chamber lens sits like that in front of the pupil. And there's 2 flavors to these. We can either go sideways and support the lens. You can just see that little angle at the edge of the eye. So that's where the little arms sit. The other approach is to go backwards within the eye onto the iris tissue. And that's called an iris claw lens. So they sit in the same position, but just attach in different ways. If we're going behind the pupil into the posterior chamber, then this is the position that the lens was sitting in before, but we no longer have the zonules or the capsule to support it. So we have to go far sideways in this circumstance and go into the wall of the eye itself called the sclera. So we call this scleral fixated. So the lens implants themselves, so they've evolved over time and there's different ones around. So the angle supported one is a very clever design actually. It emerged 20 or so years ago. It's all one piece of rigid plastic. So this one we can't roll up. So it does need quite a big incision into the eye to get it into the eye. But the design is such that those arms become springy. So you can imagine if you push them, they have a little bit of a give to them. They're slightly springy in their nature. So this allows it to support itself really well in front of the pupil without touching anything else. The bits that do touch the eye are these 4 corners. There's 4 little rounded blobs on the corner. and the inside of the eye is obviously circular. So these 4 points touch the inside of the eye minimally and give a good level of support. Going back to our cross section, that's where it's sitting. It's sitting in front of the pupil, and those legs are supporting outwards into the angle. This gives a really nice stable position, but it does have some disadvantages. So because the lens is sitting quite close behind the cornea, actually the back layer of the cornea is the most sensitive. So if that starts to rub on the cornea over time, the cornea can become irritated and can become cloudy, which sometimes is a cause to remove the lens. It's not common, but it can happen. The other important issue is that those arms are sitting in that angle, as we said, and that's where the fluid tends to drain out of the eye. So if that area is irritated, it can cause the fluid to not drain as efficiently, and that can lead to the pressure in the eye going up, which can cause the other issue of glaucoma. So yeah, those complications are rare, but they are possible. The iris claw lens is the other type of lens that sits in the anterior chamber. So this design was really, really clever. Again, it's a one-piece lens. It's all made of a rigid plastic with a central disc, but this time they manufactured it to have little pincer claws on either end. So the way you use this is you grab a little piece of the iris tissue from behind it. Once it's in the eye, you can manipulate the iris tissue to just have a little fold going through those pincers. So it's a small thing, but actually it gives quite a good fixation, and again, a very stable position and potentially a very good quality of vision. So it's holding itself on just with that little pinch of tissue. Again, it's sitting in the front part of the eye, the anterior chamber, but as we said, it's supporting itself backwards onto the iris tissue. The main disadvantage of this is that the iris wants to move. So if you've ever noticed going from a light room to a dark room, your pupil wants to change. So the pupil wants to get bigger in dark conditions and smaller in bright conditions. So actually we're pinching a little piece of tissue rigidly that wants to move. So we are going to cause some rubbing over time. And that rubbing is on blood vessels and nerves and connective tissue, so that can stir up some inflammation. Also, similar to the last lens, it's quite close behind the cornea, so that can cause irritation of the cornea over time. But again, generally that doesn't happen. Generally it works well, but there is that risk with these lenses. So moving to the back of the eye now, so this is more my domain because I tend to operate on the retina. The initial incarnation of this was to use a stitch to hold a lens in place. So 20 or 30 years ago, we had rigid lenses that looked a bit like this. So all one piece of rigid plastic, but they had these nice eyelets in them that allowed us to pass a nylon suture through and just tack it to the wall of the eye on the inside. So again, it needed a big incision to get it in. But it stayed in quite a nice stable position behind the pupil. This worked really, really well, but then we found that about 10 years later, there was a tendency for the nylon suture to snap. So unfortunately, there's been quite a few redos where we had to take the lens out and put a different one in. So the lifetime on this, about 10 years, not ideal. The more modern incarnation of this is a foldable plastic lens. So this one can be rolled and inserted through a small incision, but this one has 4 sort of dog ears on it, and we can use this to pass a lute suture through. So we've essentially got 4 little holes in the wall of the eye, and the suture tied twice. So this gives 4-point fixation, which is a bit more stable. And the way we addressed the suture breaking was to use a Gore-Tex suture. So Gore-Tex is the same material that you find in your waterproof jacket, but it's quite stretchy and pliable, so it doesn't have the same tendency to snap over time. I prefer not using a suture because of those issues. So if we're not using a suture, we've got 2 options really. The first option is to use a 3-piece lens, which was originally designed for use inside the capsule. So this is not using it for its intended purpose, but it seems to work quite well in another way. This lens is foldable, so again, a small incision to get it in the eye. It has the disc in the center and then some springy arms coming out from either side. So actually, if you bring those springy arms through the wall of the eye, you can then use a little bit of heat to just melt a bulb, or what we call a flange on the end of it, and that grips the lens quite well, so it can be held in place. So that's a nice use of a lens that wasn't intended for this purpose. We've recently had a lens which was custom designed for this purpose, come out of Italy. So this is a flexible lens. It can be rolled, so again, a small incision to get it into the eye. And this nice design means that you can actually grip those little T-bars on either side and pull on it, and it will stretch. So it's really very flexible. And again, we're taking those little T-bars on either side and externalizing them so that the wall of the eye grips onto it there and there. So that gives a really nice stable position, and potentially a little bit more stable than just having the two springy arms. So we've got the sutured and the non-sutured techniques. All of these techniques sit, as I said, behind the pupil in a more natural position, but require a slightly different way to attach the lens to the inside of the eye. The disadvantages of this method are that the lens can be liable to tilt. So with the anterior chamber lenses, the anatomy of the eye is quite robust and fixed, whereas we don't really have any sort of defined points here. So we're relying on our best measurements to try and get the lens in a stable position, but it's possible for the lens to tilt, which can compromise the quality of the vision. The other point to add is that anytime we pass a stitch or one of these little plastic haptics through the wall of the eye, we are making a hole that won't heal, essentially. So we're making a weak point in the wall of the eye. So I'm very hesitant to use this technique in people who do contact sports or people who are liable to trauma, because if you get a big thump on the eye, it's unlikely to happen, but it is possible that the eyeball splits, which can be disastrous. So I think in people who live a normal lifestyle, absolutely fine, that's not an issue. But if you're a rugby player or a boxer, then that's a very different proposition. So these techniques do have their limitations as well. My technique is this one. So a very clever chap called Shin Yamane first published a technique in Japan, 2017, so about 5 years ago. He described the normal lens implant, as we've said, used in a slightly different way. So previous to this, we were using the stitches, the sutures, but he described this technique of using a hot wire to burn the end of the plastic arm to form this little bulb, as we described. So a very simple technique, but actually very elegant. And the main thing about this is that the lenses are stock. So we have hundreds of these lenses on our shelves, and we can do the measurements for each person and then just pick an appropriate lens. So that can happen in 30 seconds. That's a very quick process. Whereas custom design lenses, they will take and if we drop that lens on the floor by mistake, then suddenly we're back to square one and we've got a big problem. So actually having a stock lens is a really nice way to do it, because you're much more flexible. If something goes wrong and the lens snaps, you can just use another lens. So it's a really nice way to do things. This is a three-piece lens that we inserted this week again. Yeah, you can see as in the diagram, you can see the central optic is clear, and that is the bit that's used to focus the light. And then these little blue arms are the haptics, which we pass through the wall of the eye, and then just a gentle melt on either side to hold them in place. Because this is designed for use in the capsule in a normal cataract surgery, we have to say that this isn't licensed. So it's a licensed use. It's licensed for use in the eye, but the manufacturer applied for that license to be used in the capsule. So we're using a lens that we know works well in the eye for a slightly different application. This is my technique. So again, we're going back to the surgical image. We haven't got any videos here, but I'm just going to show you a little bit of what we do using an animation. So if you are particularly squeamish, feel free to look away at this point. So the first step is to make a little incision in the cornea, as we would do in a normal cataract surgery. So that's about 3 millimeters in size. That allows us to access the lens. So we take away the lens, take away the capsule, take away the zonules. So we're left with a clear eye with no lens in it. Next step is to roll up our 3-piece lens and insert that into the eye behind the pupil. So that will sit quite nicely, but it's not fixed. If we move the eye, it will move around. So to fix it in place, we need to measure where we want to fix it quite carefully. So we need to measure 2.5 millimeters from the limbus. The limbus is the border between the colored part of the eye and the white. So you can just see that circle going around the eye. We measure 2.5 millimeters from that. And then we use a little hollow needle, which we insert into the eye. And then we can dock the plastic arm on the inside hollow of the needle, so it sort of grips it. And then we bring the needle out of the eye, and that pulls out the arm, so it externalizes it. So yeah, it's quite a basic technique, but used in a clever way, it can give a very neat result. So that's one arm, and then we use a hot wire to burn the flange. And then we repeat the process for the other side, again at 2.5 millimeters. So we know we're very sort of accurate with where we're placing the lens. Burn the arm, and then the lens is secure. To make it secure in the long run, we need to just push those arms back into the eye so that the lens will rotate a little bit. And then those flanges half bury, so they don't tend to fully bury, and the lens rotates around a little bit. The final step, the white skin of the eye is actually quite loose. So you can gently grip that white skin and just bring it over those blue flanges, and that will cover them over so they're sealed away from the elements and watertight. And that's very important in preventing infection. So those blue little dots will be visible long term, but I've exaggerated them there. So your optician might see them at your optician's check. But if you meet a friend down the pub, they're not going to be noticeable. They're very, very tiny little blue dots. And otherwise, it looks like a normal cataract surgery. So you've got a nice plastic lens sitting behind the pupil. So once the pupil shrinks down, it's not noticeable at all. So quite a nice way to achieve a normal position for the lens. As I said, this technique was invented in 2017, so we've got about 5 years of follow-up, probably more for the original guy who invented it, but it seems to be working really well. So this paper came out from China last year. It describes 18 patients specifically with Marfan syndrome, 11 patients and 18 eyes, and they used exactly this technique and had a really good outcome. So none of the patients had any major complications. About a third of them had what we call iris capture. So that's the pupil just coming back over the lens slightly, but that tended to settle over time. So everything moved into a good position eventually. And I think this quite accurately mirrors my experience as well. I think we're having good results in general. The iris capture is possible, but does tend to settle. It's a nice technique that's very widely available, gives us some good results. So just to summarize, really, Marfan syndrome, the main effect on the lens is the stretch or breaking of the zonular fibers. The natural lens can sublux, or if you're very unlucky, dislocate over time. If the lens is slightly out of position, it can mean that you're reading quite a good level on the eye charts at your opticians. But the quality of the vision is not as good, so it's quite difficult to quantify that, and people can be suffering despite having a good line of vision that they can read. There's loads of different techniques out there. I've shown you a few different lenses. The fact that they're all out there suggests that none of them are perfect. So they've all got pros and cons, but I think possibly some of the ones that we've been using in the past do have more disadvantages than the newer techniques. With my job, I have the most trust in this posterior approach, the scleral fixation lenses, because I think it's nice to put a lens in the same position that it was when you were born. And I think probably this has the fewest side effects in the long term. The long-term data we don't have yet, it's building, but I think the initial data is encouraging. And as I said, these new lenses are coming out, and there's different ways to address the same problem. So I think if anybody's involved in making this decision for yourselves or family members, just speak to your surgeon, say, which technique do you like? Are there any other guys out there doing different things? Should we be thinking about anything else? I think there's no hard and fast way to solve this problem. But it's about finding the way that best suits you. And I think also best suits your surgeon, because your surgeon is somebody who's going to be taking you through this very stressful part in your life. And I think if they're comfortable with the technique, that's when you're going to get the best outcome, really. So yeah, it's about finding the best solution for both the patient and for the surgeon as well. So many thanks for your attention. I'm happy to take any questions.
Thank you very much, Ben. Thank you. A question has emerged whilst you were speaking from Kerry, who has written to say that her son had an iris claw implant a year ago. Sadly, not a good result due to iridokinesis. She's wondering if we should ask for scleral fixated for him. He's 26 and had his lens removed at the age of 9.
So yeah, that's a very typical situation. So I think the scleral fixation can be a little bit more tricky in the younger age groups. So the complicating factor really is the gel within the eye. So in younger people, the gel is quite firmly attached. So we try not to remove the vitreous gel if we can avoid it. So if we're operating on somebody in the younger age groups, then yes, we try to avoid going at the back of the eye for the reason of not removing the gel. So usually the tactic would be to keep going with contact lenses or however best you can until the adult age group, and then scleral fixation becomes more of an option. So yeah, I think if you're getting issues with an iris claw lens, then definitely talk about other options. So it's perfectly possible to remove an iris claw lens and then go for another option. Usually it's the adult age group that does better with scleral haptic fixation. So I wouldn't jump on it as the ideal technique. But certainly if you're having issues with iris claw lenses, and scleral haptic fixation is a very good way around that.
Thank you. And Robin would like to know if you think that the Marfan eye wall, the sclera, will be strong enough long-term to retain the leg of the lens.
I believe so. So we're making a very small incision. So we're using a tiny hollow needle. So it's really just separating a few fibers within the sclera. And then actually, I think you'll get a healing process around it. So probably if you implanted one for 10 years and then took it out and looked at the hole that's remaining, I think probably it would have restructured. So probably the eye responds to it by strengthening that area. So I think probably, yeah, of course, it's possible for these lenses to slip and the leg to dislocate, but we don't tend to see that in the initial period. So my suspicion is that the body responds to the small insult, the surgery, by repairing and strengthening. And certainly that process is, virtually normal in Marfan patients.
Thank you. And Chase would like to know, what does recovery from these surgeries tend to look like, and does it differ much between the surgeries?
I usually say to my patients, don't expect any good vision for 2 weeks. So a normal cataract surgery can be better the next day. If you've heard people talk about a normal cataract surgery, it can be an overnight change. And I usually say, don't expect that. I think probably the eye takes about 2 weeks to start feeling a bit normal again. So you will have a level of vision day one after the surgery. But for everything to settle and for everything to knit together, it usually takes about 2 weeks.
Thank you. And Amanda's written to say, I had 2 dislocated lenses. One was removed with the vitreous gel, and I was given a replacement lens, posterior haptics. This failed disastrously after a few weeks and was subsequently removed. What are the risks of not having the other lens removed long term? I have 20/20 vision using contact lenses, and I'm happy with that.
So that sounds like we've still got a lens inside the eye. I think that's the implication. So if we've got a plastic lens that's dislocated inside the eye, usually that is very well tolerated. There's a small chance that it irritates the retina, and often people will describe, oh, sorry, it's her original lens. Okay, that is an even safer situation. So the natural lens is nice and round. It doesn't have any sharp edges. So it's actually very safe to have that sitting inside your eye. But often when you lie down, you'll be aware that it drifts over and the vision suddenly changes. Yeah, contact lenses are a fantastic way to manage that. Non-surgical, so no risk of infecting the eye or anything like that. There's a small risk of getting an ulcer or something like that with contact lenses. But you know, if you're careful with your contact lenses, and that's a fantastic solution and avoids the surgery altogether.
Amanda said she was only persuaded to have the replacement lens because I was told I had to have the lenses removed. So that was her situation.
Yeah, it can be very difficult, and some people are making do, and actually they're making do with quite a low quality of vision. So in some situations, you don't know what the visual potential is unless you give it a go. And in most people, they will get some cataract over time. So yeah, if we see a cataract, we like to remove it because it can cause other problems. But if you've got a healthy natural lens that wants to dislocate and you're doing well with contact lenses, then that's a perfectly acceptable situation.
Yeah,
Victoria,
oh yes, I'm sorry.
Can we make this the last question because we need to get back on target?
Yes, sure. It's not
back
a question.
On schedule. Yeah.
It's not a question, but a comment from Kerry to say her husband had his natural lens dislocated nearly 40 years ago. They're still in his eye. Gosh,
yeah, that's a long time, and you know that just reinforces a point, doesn't it? The natural lens it doesn't irritate the eye if it moves. We're just aiming for a good quality of vision. That's the main thing.
Okay, thank you very much, Ben. Thanks so much for everything.
Thanks for having me.